all. I am Fadila Shaib, speaking to you from WHO headquarters in Geneva and welcoming you to our virtual press conference on global health issues today, Friday, 1st of November. Let me introduce my colleagues who are here in the room, starting with Dr. Tedros Adhanom Ghebreyesus, WHO Director General, Dr. Maria van Kerkhove, Director ad Interim, Epidemic and Pandemic Preparedness and Prevention, Dr. Teresa Zakaria, Incident Manager for Conflict Escalation in Israel and Occupied Palestinian Territory, Dr. Teresa Kasaeva, Director, Department of TB. We have also with us Dr. Michel Yao, Incident Manager for Mpox Response. And we have also with us Daniel Torrington, who is Director of Resource Mobilization at WHO. We have several other colleagues online. I would like just to introduce for now Dr. Rick Pieperkorn, who is the WHO representative for OPT from Gaza. So welcome, Dr. Pieperkorn. Now, without delay, I would like to hand over to Dr. Tedros for his opening remarks. Dr. Tedros, you have the floor.
Thank you. Thank you, Fadila. Good morning, good afternoon, and good evening. On Tuesday this week, WHO published this year's Global Tuberculosis Report, showing that 8.2 million people were newly diagnosed with TB in 2023, the highest number recorded since WHO began global TB monitoring in 1995. The number of TB-related deaths declined for a second consecutive year, as access to services for prevention, diagnosis, and treatment continues to improve after the disruption caused by the COVID-19 pandemic. For the first time, the report provides country estimates on the financial impact of TB, showing that half of the households it affects face catastrophic health costs because of it, meaning they spend more than 20% of annual household income on diagnosis and treatment. TB is the definitive disease of deprivation, disproportionately affecting the poorest people in 30 high-burden countries. Just 8 countries account for 2/3 of all TB cases and deaths: India, Indonesia, China, the Philippines, Pakistan, Nigeria, Bangladesh, and the Democratic Republic of the Congo. Multi-drug-resistant TB also remains a serious challenge. Treatment success rates for people with MDR-TB have increased to 68%, but less than half of patients estimated to have been diagnosed and treated. About 1/4 of the world's population is estimated to have been infected with TB bacteria, but most people do not develop TB disease. In up to 10% of people, the infection is activated and they become sick, often because of undernutrition, HIV infection, alcohol use disorders, diabetes, and smoking, especially among men. This could be one reason why 55% of people with TB are men, while 33% are women and 12% are children and young adolescents. At last year's UN General Assembly, world leaders made concrete commitments to improve access to prevention, diagnosis, and care, to protect households from its financial impacts, to develop a new TB vaccine, and to increase funding for TB implementation and research. WHO urges all countries and partners to make good on those commitments. The fact that TB still kills and sickens so many people is an outrage, when we have the tools to prevent, detect, treat, and end TB. Now to the outbreaks of Mpox in Africa. So far, more than 50,000 people people have been vaccinated against Mpox in the Democratic Republic of the Congo and Rwanda, thanks to donations from the United States and the European Commission. Last month, WHO, the Africa CDC, CEPI, Gavi, and UNICEF established an access and allocation mechanism, the AAM, to support equitable and timely access to Mpox vaccines. This week, the AAM is allocating almost 900,000 doses of vaccine to 9 countries based on public health need, especially those with significant transmission of clade 1b virus. Countries are being informed of allocations today, and WHO and our partners will announce the details soon. This is the first allocation of almost 6 million vaccine doses that we expect to be available by the end of 2024. These vaccines are being used in a phased approach as part of the comprehensive global and continental strategy. I thank the countries and partners that donated these vaccines: Canada, the United States, the European Union, and 12 of its member states, and Gavi. This is an important step towards bringing the Mpox outbreaks under control as part of WHO and the Africa CDC's shared strategic response plan. It's important to underscore that vaccination is only one part of that plan, alongside case finding, contact tracing, infection prevention and control, clinical care, risk communication, and testing. Although testing rates have risen significantly this year, only 40 to 50% of suspected cases are tested in DRC. In the 2 past weeks, WHO has approved 2 more tests for emergency use listing to enhance access to quality-assured products. We're also working with manufacturers of these products and regulatory authorities in affected countries to facilitate domestic registration or emergency listing. Now to Gaza. This week, Israel's parliament, the Knesset, passed 2 bills banning the United Nations Relief and Works Agency for Palestine refugees in the Near East, or UNRWA, from operating in Gaza. UNRWA is one of the largest providers of essential health services in Gaza, providing critical health and humanitarian support for over 7 decades. Every day, it provides thousands of medical consultations and vaccinates hundreds of children. Many humanitarian partners rely on UNRWA's logistical networks to get supplies into Gaza and onward to where they are needed. The UNRWA staff that WHO works with are dedicated health and humanitarian professionals who work tirelessly for their communities under unimaginable circumstances. Israel's decision to restrict UNRWA's operations contravenes Israel's obligations and responsibilities and jeopardizes the lives and health of all who depend on these essential services. This ban will not make Israel safer. It will only deepen the suffering of the people of Gaza and increase the risk of disease outbreaks. Let me be clear. There is simply no alternative to UNRWA. Tomorrow, the 3rd phase of the polio vaccination campaign is set to begin in the northern part of the Gaza Strip, after it was postponed last week due to intense bombardment, mass evacuation orders, and lack of access or assurance of humanitarian pause. The humanitarian pause necessary to conduct the campaign has been assured, but the area of the pause has been substantially reduced and is now limited to just Gaza City. The final phase of the campaign had aimed to reach an estimated 119,000 children under 10 years old. But achieving that target is now unlikely, as conditions in Northern Gaza get worse every day. In the past 2 weeks, WHO has conducted 6 missions to Northern Gaza to bring medical supplies and food for hospital staff and patients when permitted, and fuel to keep the generators working. In recent days, following intense fighting, a siege and a raid, Kamal Adwan Hospital has been reduced from a hospital helping hundreds of patients with dozens of health workers to a shell of itself. WHO helped to move the most critical patients to Nasser and Shifa hospitals, where they can receive a higher level of care. Now, a few dozen patients remain at Kamal Adwan with a handful of staff to care for them. An attack and subsequent fire on one of the floors of the hospital has destroyed some of the supplies we delivered. We're trying to reach hospital staff for more information. To say more, we're joined today by WHO's representative to the occupied Palestinian territory, Dr. Rick Peppercorn, who joins us from Northern Gaza. Rick, over to you.
Thank you very much. Dr. Tedros and colleagues. I hope you can hear me clear. Currently in Gaza City. I want to continue maybe where Dr. Tedros ends and focus very briefly on polio and then to the health situation in the north. So, as we know, the polio campaign resumes in the Northern Gaza tomorrow. Just want to remind everyone of what the target was. The target is to cover 591,000 children under 10 years of age with the second dose of the novel oral polio vaccine type 2. The vitamin A, by the way, will also be co-administered alongside the polio vaccine to help boost the overall immunity among children and between the ages of 2 to 9 years. We've seen a successful implementation, in the central and the southern zone, which actually reached more than 451,000 children and more than 364,000 children received vitamin A. That was actually more than 96% of the target. But the third phase, Dr. Tedros there was a need to postpone and delay because of the lack of access, but also the assured comprehensive humanitarian pulses, intense bombardment and mass evacuation orders. So we currently have a humanitarian pulse necessary to conduct a campaign. However, the area which this pulse is covering has substantially been reduced compared to the first round of vaccination in Northern Gaza. It's mainly limited to the broader Gaza City. And what we have seen and witnessed, and personally I witnessed, we saw approximately 100,000 people have been forced to evacuate from the North Gaza, fleeing North Gaza to Gaza City. We still estimate, it's very difficult to estimate, but we estimate that approximately 15,000 children under 10 years in the towns of North Gaza, like Ghebreyesus, Beit Lahia, Beit Adhanom, still remain inaccessible and will be missed during the campaign. So this is not an ideal campaign. I want to stress that. It's a compromise campaign. And to interrupt polio virus transmission, you want to get at least 90% of the children in every community, which will be challenging. And we are focusing in the north of Gaza on an estimated 190,000. The good news is that in the first rounds, we achieved over 90% in northern Gaza. So there is some level of protection as well. So despite this lack of access to the all eligible children in Northern Gaza, the Polio Technical Committee, and I want to stress that is the Palestinian Ministry of Health, the World Health Organizations, UNICEF, and UNRWA, and many partners, has decided to take this issue to resume the campaign to mitigate the risk of a long delay in reaching as many children as possible with the vaccine. And also, of course, including all those which have recently been evacuated to Gaza City from the north of Gaza. The microplans have constantly to be updated. There's more than 200 fixed team and mobile teams. They are ready and operational over the coming 3 days. The time for the humanitarian pulse has been extended by 2 hours between 6 to 4, which is appreciated. I want to say something about the health situation in the north, and specifically the northern parts of Gaza, and related to also the missions to Kamala 1. So over the last 3 weeks, WHO, we managed 6 missions to the north, and delivering what we regularly do: fuel, essential medical supply, blood, food for water and patients, water for patients and staff. And we transferred internal medevacs approximately 60 critical patients from Kamala 1 to Shifa, and some of them onward to the south with the Palestinian Red Crescent Society in Qadrs. I was on 3 of these missions on the last 2 weeks, complex and high risk. I want to stress that many of the WHO missions planned in October, they were denied, delayed, or impeded. One of the missions I was on the last moment, we were not allowed to bring the fuel, supplies, blood, and food for water and patients. Dr. Tedros referred to the siege in Kamala 1, and after that, just 1.5 days ago, on 31st of November, that their store on the 3rd floor was hit, and also contains some of the supplies from WHO, but also damaging the desalination station, which provides water to dialysis. 1 nurse and 3 others were injured. The latest information we have about Kamala 1, there's 55 nurses and 3 doctors available, and approximately 120 patients. When we were the last, just a couple of days ago, on the 28th of October, we still saw this constant stream of trauma patients, and then, of course, a lack of capacity to operate that with so few medical doctors and nursing staff. Just to summarize that there were 3 partly functional hospitals in the north of Gaza: Kamala 1, Al-Ada, Indonesian. Indonesian is currently not functional anymore. It's not functional and it's damaged. Kamala 1 and Al-Ada are minimum functional. WHO, we plan another support mission to Al-Ada and to Kamala 1 coming Sunday, bringing supplies and also probably again transferring critical patients to Shifa. I want to stress again, it is critically important that these hospitals remain functional. They need and deserve all the support they can get. My last point, what I want to raise, is maybe a small positive point. Having been so often coming to the north and to Shifa, and that is, I think, an example of the resilience of health workers, but also partners like WHO and many others. Shifa is currently functioning again as a mini hospital. It has an emergency ward, which is rehabilitated, a few operation theaters, intensive care unit, and approximately, when I was there a couple of days ago, approximately 9 general and large surgical operations per day on average. There's a vascular and a thoracic surgical procedures take place, along with general surgery and trauma and orthopedic procedures. And given the influx of injuries in Northern Gaza, Shifa is actually once again becomes a referral point, a referral hospital. That's where we transferred most of the critical patients from Kamala 1. And in the middle of this destroyed and damaged buildings, you also find a hemodialysis unit, which is working again with 25 machines, it used to be 60, providing hemodialysis to 63 patients twice per week for 4 hours. So as WHO, we support Shifa with regular medical supplies and fuel, but also we support by this internal emergency medical team in collaboration with MAP UK. we plan and assist also in future expansion of the bed capacity. I want to add that because I think it's an example, and we've seen it in many hospitals, both in the north and the south, even when they became from partly minimum functional and non-functional, that they bounce back with support. And we should continue to provide the support and make sure that they become not only partly functional, they become functional again. Over to you.
Many thanks to you, Rick, and to all our WHO colleagues and all humanitarian partners who are working in unimaginable conditions. Once again, the ultimate solution to this suffering is not aid, but peace. Fadila, back to you.
Thank you, Dr. Tedros. I will now open the floor to questions from journalists. If you want to ask a question, please raise your hand using the raise your hand icon. I will start by inviting Stephen Cullen from Wall Street Journal to ask the first question. Stephen, can you hear me?
Yes. Can you hear me?
Yes. Go ahead.
Thank you very much. My question relates to UNRWA, and I note the statements by many UN officials, including yourselves, about the indispensability of UNRWA to the humanitarian response in Gaza, as well as essential services in the West Bank and East Jerusalem. I wonder, though, what's being done, given that there's a 90-day implementation period for the law. What's being done at the moment to, aside from statements, to either push Israel to drop the law, to mitigate some of its effects, or to prepare for the eventuality that if that doesn't happen and the law is implemented in 90 days, that these services, that UNRWA likely won't be able to provide these services. Is WHO preparing itself to scale up and step in, at least where it concerns health services and relevant functions, to take over some of the capabilities that UNRWA currently provides?
Thank you, Stefan. Maybe we can start with Dr. Pieperkorn.
Yeah, let me start. I think the DG made it very clear. So the UN and no one in the UN can replace UNRWA. So UNRWA is vital, and not just for health, where they play a very critical role in the area of primary healthcare in Gaza and also in the West Bank, by the way, in East Jerusalem. But they're like the engine block of the humanitarian support. And not just in health, look at education, wash, shelter, but also the logistical support, etc. So there was just a meeting with the humanitarian country team as well, and the AC also made it clear, and I very much agree, the UN will not replace UNRWA. And are we working closely together with UNRWA, and are we supporting UNRWA? Yes, of course. WHO is supporting UNRWA, and we are assisting with essential medicine and medical supplies to make sure that those primary healthcare clinics can work, and that they can deliver. So, but I want to say what we expect as well, that member states and overall that, and I think the DG made it very clear, UNRWA essential for the functions in occupied Palestinian territory, Gaza, West Bank, East Jerusalem, not to be replaced by any UN AFP. UNRWA should be supported instead. Over to you.
Thank you, Dr. Pieperkorn. Now I would like to ask the next journalist to ask a question. It is Belissa Godino from W Magazine. Belissa?
Thank you for taking my question. I would like to know if there is any update regarding the war in Ukraine. Thank you.
any update on the war in Ukraine? Belisa, let me maybe give the floor to Dr. Teresa Zakaria.
Thank you very much for your question, and I think it's also important that it's true that what is happening in Gaza, in the occupied Palestinian territory, and more increasingly in Lebanon is really intolerable. But many countries, indeed, across the world continue to face atrocities, and one of them is Ukraine. The health situation in Ukraine is not getting any better. We continue to register attacks on healthcare. We continue to register loss of functionality of health services, and people continue to suffer. This war has been going on since 2022, and the coping capacities of the entire population continues to be decreased, continues to be impacted by just the length of the hostilities, but also because of that loss of hope that normal life would come back. Ukraine, prior to the most recent escalation in 2022, already had a huge burden of non-communicable diseases, of mental health problems. And we also need to remember that this war didn't just start in 2022, but that conflict in the eastern part of the country has been going on for many, many years prior. And so our call is the same for all of these countries facing conflicts, is that we need peace for all of them. We need hostilities to end. We need health to stop being attacked and ever so frequently at the moment, and to give space for the health system to recover and for the population to also recover to their optimal health status. Thank you.
Thank you, Dr. Teresa Zakaria. Waiting for more questions from journalists. We have several of them online, so we will give them a few seconds. Yeah, we have Robin Miller from Agence France Presse. Robin, you have the floor.
Thank you. On the pandemic agreement talks due to begin next week, what would you like to see countries achieve by November the 15th, and specifically, without perhaps being included at this stage, how would the agreement make countries any safer if another pandemic came around? Thank you.
Thank you, Robin. Let's maybe start with Derek Walton, who is our legal counsel, and then I will invite others who want to complement. Derek, you have the floor.
Thank you. Well, perhaps I can just explain what's happening in the next couple of weeks. The IMB, which is the intergovernmental negotiating body to actually negotiate the pandemic agreement, is meeting for its 12th meeting, and this is the key moment for deciding whether we're going to go ahead with a special session of the World Health Assembly before the end of the year. The Health Assembly in May decided that the pandemic agreement would be agreed either next year at the Health Assembly in May, or, if possible, sooner, before the end of 2024. And the deadline for making that decision falls during the next 2 weeks while the IMB is carrying out the next round of negotiations. So the hope is that once during the discussions this week and next week, a decision will be able to be made to enable us to know whether we're going ahead with the special session before the end of the year. And if so, that would be the special session that adopts the pandemic agreement.
Yes, Maria?
Yeah, thanks very much. So maybe I could just add to that and just say the hope that we have in terms of the discussions. This is a member state-led negotiation, and can say that we're really grateful for the efforts that the member states are putting forward to come to an agreement on this. We are all hopeful that this will be finalized as soon as possible, because we are experiencing outbreaks, emergencies that are happening right now. we are witnessing and observing circulation of pathogens that will become the next pandemic. Maybe not now, but at some point in time. So the world needs a pandemic accord. The world needs an agreement by all member states, driven by member states, in which we as the Secretariat will support with partners, with many partners around the world, in terms of better pandemic preparedness, prevention, readiness, response. And I think we're all hopeful. I think it's up to the member states. And I think one of the messages that we keep hearing and that we keep promoting is that it can be done. And it will be done. Maybe we should say that. But we have a lot of hope for the discussions that will happen next week. Most of the agreement is agreed. There are some points that are left to come through. But again, the countries are sitting there in good faith to really come to those agreements and to work through that. So we're quite hopeful for next week that a lot of that text will be greened and that they will move forward, and we're hoping that it will be finalized as soon as possible.
Thank you so much. I would like now to invite Carmen Paun from Politico to ask the next question. Carmen, you have the floor.
Thank you so much, Fadela, for giving me the floor. I was wondering how worried you are about the avian flu situation in the United States. We just heard that a pig was found to be infected this week. The milk is going to be tested here. Is there something that could be done or should be done to make sure that this doesn't spread to more species and somehow it doesn't become, more transmissible in people? How do you assess the situation there? And if I'm allowed, a second question on the pandemic treaty or agreement, how much do you think the results of the U.S. elections, which we should know at some point next week, might weigh in the decision to have a special session on the pandemic agreement by the end of the year? Thank you so much.
Thank you. I would like to give the floor to Dr. Maria van Kerkhove for the first part of the question. Maria?
Thanks, Fadela, and thanks for the question. So we are concerned about the avian influenza situation globally. There's a lot of attention right now to H5N1 in the U.S., as there should be, because we are seeing a number of herds, dairy cattle herds, being infected and being reported. We have a report of infection in swine in the U.S. for the first time, and we are seeing human infections, most of which, almost all except one, with reported contact with infected animals. There's a lot that's being done in the U.S. We should say that first and foremost. First of all, to protect human health, to make sure those that are in contact with infected animals have the appropriate personal protective equipment, that when any contact with those animals is occurring, that it is done as safely as possible, that there's increase in testing that's happening among those who are exposed so that we can identify the viruses in those individuals, provide them with appropriate care. Luckily, these individuals have experienced mild disease so far, and that's a good sign, but we need to assess each of these viruses. The viruses are being shared with WHO collaborating centers through our global influenza surveillance and response network to assess any changes. And what's important about that is to determine if there are any changes, what would need to be done in terms of our readiness activities for avian influenza. On the animal side, there is also a lot being done, and I should highlight some of the additional actions that the USDA highlighted in the last couple of days with regards to bulk testing of milk, which is a good sign. But there is a lot of effort to look at how this virus is being transmitted between dairy cattle, between the herds, but also to other species. And as you point out in your question, it's really critical that steps are taken to minimize circulation in the animals and to any new species. Certainly when any new species are infected, as we saw with the dairy cattle recently, but also in swine, it's not the first time we've seen H5N1 in swine globally, but it is the first time in the U.S. Our concern is raised. Certainly, with opportunities of these viruses to circulate in different animal species, there's the possibility of reassortance. So what we want to see is more efforts in the animal sector, as well as not just on the surveillance side, but ensuring food supply, ensuring food safety, making sure that that isn't impacted, because of course we want to ensure that not only we focus on human health, we focus on animal health as well, and the trade and the livelihoods of individuals. But certainly we are concerned. Certainly everything that we and our member states are doing in terms of pandemic readiness for avian influenza is important for now as well as in the future, because we don't know when. We don't know if this virus will be the one that will change, but we don't see any changes in the virus itself right now to suggest changes in transmissibility or changes in severity. But this is something that we can't take for granted, and we need to make sure that the information sharing is happening as quickly and as readily as possible. Sequences are shared from animals, from humans, so that our collaborating centers can do rapid risk assessments of these, and we can inform the public of any changes. Thanks.
Thank you, Maria. Maybe for the second question, I turn to Derek Walton to take it. Derek?
Thank you very much. Yes, an obvious question of the United States elections taking place next week. It's clearly interesting timing that the elections take place during the next meeting of the Intergovernmental Negotiating Body. But it's important to remember the United States is just one of 194 member states of WHO who are taking part in the negotiations, and it's really a matter for those states to decide what factors to take into account when taking their decisions. So I think I'd have to refer you to the United States delegation for them to advise you if it would make any difference to their position, and to the member states generally who will have to take this into account or not as they take their decision in a week or so's time. Thank you.
Thank you so much, Derek. I would like just to remind journalists that Dr. Rick Pieperkorn is still with us online, so if you have questions for him, please do. Now, I would like to invite Christian Ulrich from DPA to ask the next question. Christian?
Thank you very much, Fadela. My question is to Dr. Tedros and is with regards to Gaza. Given the decision by the Knesset on UNRWA and also the bombardments that are impeding the vaccination campaign, are you yourself personally in touch with the Prime Minister? And what would be your message to Mr. Netanyahu? Thank you.
Yeah, thank you. I think my colleague Rick had already said about UNRWA and covered it very well. I didn't want to add, but if you're asking again, maybe I would like to say a few things. First of all, the decision by the Parliament is very disturbing because UNRWA's support to the Palestinian people is irreplaceable. I said it many times that even if you combine all the UN agencies operating there, they cannot replace UNRWA. So if UNRWA cannot function in the occupied territory, then it means it will have a serious impact on the Palestinians. As you know, UNRWA provides, I think has been said earlier, many services, very essential services like health, education, and other services to the people of Palestine. And as we know, the reason behind this decision by the Parliament or Knesset is because there were some people who have been found to be involved with Hamas, I think about 9 people from UNRWA. But of course the investigation is underway. But even if we said these people have relationships with Hamas, they cannot represent the whole UNRWA. Of course, those who have been involved, if found guilty, can be taken into account, but punishing the whole organization, UNRWA, is not right. And punishing UNRWA is punishing the people of the occupied territory, Gaza and other places. And that has to be clear. So the best way out would be and asking Israel if it can reconsider its decision. Of course, we have the 90 days, but we are asking, and many are asking, if this decision can be reconsidered. It's not about UNRWA, it's about the people who get the service, who will be impacted directly. So there are communications directly to Israel to reconsider and not implement the decision by the Knesset. And I hope that will be the case, and that's what we encourage Israel actually to reconsider. And we ask for a ceasefire and peaceful settlement and political solution, because we believe that peace is in the best interest of Israel itself and also the Palestinians. And then on the polio vaccination, as you know, it has been interrupted because of the conflict. The second round, the first round was successful, but the second, in the second one, we faced many problems. But I hope the upcoming campaign will be a success like the first one, and we hope there will be cooperation from all parties. And thank you.
Thank you, Dr. Tedros. I would like now to give the floor to Gabrielle Emmanuel from NPR. You have the floor.
Thank you very much. I had two quick questions. One, I wanted to see if there is an update on Mpox vaccination for the children, particularly in the DRC, as well as an update on kind of what the barriers have been in Nigeria to rolling out the vaccine, the Mpox vaccine there. Also, I wanted to see, hear any update on the Marburg virus in Rwanda, and particularly their relatively low mortality rate and kind of what's behind that. Thank you very much.
For the question on Mpox, I would like to invite Dr. Michel Yao, Incident Manager for Mpox, to take it. And for the Marburg, I will introduce our expert in due time. Thank you.
Thank you. Thank you very much. I'm coming back from DRC, and the Mpox response has been kicked off, but we still have to scale up. So about vaccination, we started in the eastern part of the country, North Kivu, South Kivu, and within also 4 other provinces. And so far, we have 50,000 people that have been vaccinated. About children, the work is still on, and when I was there is a research that has started, and based on this research, and with also WHO mechanism, at least for compensation and so on, we are working closely with government so that decision can be made for children vaccination. But this is not excluding also all the comprehensive interventions that we are doing to make sure that treatment is adequately provided, mainly treating comorbidity, because it's an area where we have, in addition to Mpox, measles going on, malaria, and as well as also malnutrition. So these are issues my colleague Anna Maria will add, but before that, on the other points related to Nigeria, you know, these are new vaccines that are introduced, and the approach is a targeted vaccination around the people that are at high risk around the cases. So this required a proper targeting. It's also, as the new vaccine introduced, need community sensitization, a lot of information. So all these processes are ongoing to increase acceptability, but also ensure that the vaccines will effectively contribute to at least control the case in Nigeria. So these are things that are ongoing. And lastly, next week, we are having also in Brazzaville a meeting to help countries for further detailed planning to introduce effectively these vaccines and also to reach the purpose. We have few vaccines and we need to make sure that they are effectively used in control of the outbreak in integrated manner with all the relevant intervention. So Anna Maria, if you're online, please take over and complete.
Thank you, Michelle. Just to add to your intervention, as we noted last time in the last press conference, we are really battling 3 different outbreaks, clade 1A, clade 1B, and clade 2 in the African continent. The one that is most concerning, that is for which we are observing exponential growth and expansion to areas within the DRC and in the African continent, is the clade 1B. The other key message that I would like to share is that we have observed from our analysis, at the different levels, in the country level, our regional colleagues and the continental incident management system, and at global level, that the outbreak has a varied epidemiology in the different areas. But in all, what is in common is that children are affected. Sometimes in clade 1B, the outbreaks the introduction starts with adults, but soon, as we expressed last time, includes children and adults equally. In the endemic areas with 1A, it's mostly children that are affected. So, as Michelle indicated, we are working with our partners and also encouraging the governments to consider the vaccination of infants, children, and adolescents as recommended by WHO and our strategic advisory group of experts, the SAGE. The positive also movement is that thanks to the availability of additional data, our colleagues in the regulatory team were able to pre-qualify the use of the MVA-BN vaccine for adolescents 12 and 17 years of age. So we are encouraging as a first step to protect children who are an important affected group that they endorse and apply this recommendation of WHO of vaccinating 12 to 17 years of age. And as Michelle indicated, we are discussing mechanisms to accelerate the availability of doses for children below 12 years of age, using a protocol for expanded access, with WHO offering the countries the possibility of covering any liability associated via our WHO insurance for expanded access. We think that an integrated approach covering all the targeted groups that are affected, but also including surveillance, contact tracing, access to adequate healthcare, infection prevention control measures at the community level, and excellent community engagement are critical. And if we are going to contribute to control the outbreak, particularly 1A, but also particularly clade 1B, but also clades 1A and clade 2, we need to put all these strategies together in a targeted area that goes where the virus is circulating most recently and expand the implementation of these strategies there first, with the ultimate goal, as it was discussed, of providing population immunity when we move and we are able to move to phase 2 and phase 3 as the number of doses of vaccine become available. Thank you.
Thank you so much. Regarding the question about Marburg, we have 2 experts. One of them is Dr. Zailin Kazamali, epidemiologist, acute event epidemiology unit at WHO. So Zailin, you have the floor.
Thank you very much. So regarding Marburg virus outbreak, so it's been 5 weeks since the outbreak was declared by the Rwanda government on the 27th of September of this year. And as an update epidemiologically, since as of 31st of October, we have a total of 66 confirmed cases, which includes 2 new confirmed cases that were reported on the 26th and the 30th of October. Cumulatively, we have 15 deaths reported as of 31st of October, and there has been no new deaths in the last 7 cases. This brings the case fatality ratio to 22.7%. There are currently 2 cases that are receiving care in isolation as well in the designated Marburg Treatment Center. We also have good news. 49 cases have recovered and have been discharged. Regarding testing, a number of tests have been conducted in country. This includes suspected cases as well as repeat samples from fever cases, and it's over 6,000 samples that have been tested since the start of the outbreak. In addition, regarding contact follow-up, we have 559 contacts who are listed and under follow-up as of 31st of October. The number of contacts has decreased a lot since previously reported, and this has because of several contacts have completed the 21-day follow-up from the initial cluster that were reported. Regarding the second question about the Marburg recovery rate, so historically, this is the 18th Marburg outbreak reported in history, and the case fatality ratio for this disease has varied greatly between outbreaks. There are several innovations that have been used, including intubation, as well as early presentation for care is always a critical factor in all outbreaks. So optimizing supportive care for patients, which include careful monitoring, use of intravenous fluids, early treatment of complications can really greatly improve patient survival. And also there's been great commitment as well as efforts by the Ministry of Health as well as the doctors in Rwanda that are treating the patients currently in the current outbreak. So this is good to see a CFR that is low, but historically in the 17 outbreaks that have been reported previously, around 4 outbreaks had a case fatality ratio of 30% or below. And WHO has shared Marburg best practice guidance, and we hope that we will work closely with Ministry of Health to gather more information to document best practices from this current outbreak. So just before I finalize, so WHO continues to support the government of Rwanda to respond to this ongoing outbreak. Several activities are occurring in country, and considerable progress has been made in controlling this outbreak. However, with still cases emerging, even though in small numbers in the last week, we still need to maintain vigilance and sustain the response operations, which is quite vital. Thank you.
Thank you so much, Zailin. And now I would like to give the floor to John Zarakostas. John, you have the floor.
Yes, good afternoon. Thank you, Fidela. I've got one question for the legal counsel. Derek, if you could please elaborate, when is the deadline for the member states to decide whether they'll push forward for a special session or not? Is it sometime between the 4th and the 15th of November? If you could elaborate on the precise date when they need to decide on that. And my second question is perhaps to Dr. Tedros. There's concern among many developing countries that they don't want to see a treaty with a small e for equity rather than a big E for equity. How concerned are you that what they're echoing could turn out to be reality? Thank you, sir.
Mr. Walton?
Thank you. Well, the IMB itself... Oh, sorry, I was using the wrong microphone. The IMB itself has set the deadline for making a decision to trigger the process which would lead to a special session before the end of the year, and it's Monday the 11th of November. So the decision needs to be made by then in order to put in place the machinery that would lead to a special session before the end of the year.
Thank you.
Okay. I think Dara Costa's biggie or smallie is not a bit clear. Anyway, I think in the pandemic agreement, if there is one thing that has to be very clear is the equity issue. And this is based on the lessons learned from COVID-19. In COVID-19, if the world has failed with one thing, it was the equity issue. And that has to be addressed. How big, how small, be difficult to say, but at least it has to be represented in a fair way. I mean, that I would say fair, what do you call it, representation of the equity issue, and something that can have, impact and prevent the same thing from happening in the future, the same problems that we have faced with equity. And as you know, especially Africa was left behind then, and that should not happen. By the way, while, of course, the pandemic agreement is going on, we're also doing or implementing many initiatives based on the lessons learned. And one thing that could help in addressing the equity issue is increasing local production in the south. And as you know, we have established the mRNA transfer hub in Cape Town, South Africa, and it's helping 15 countries to boost their production capacity. And we'll do other initiatives as well based on the lessons learned. But I hope in the pandemic agreement there will be at least a reasonable text that can address the equity problem based on the lessons learned. But not only equity, I think there are many other very important issues in the pandemic agreement, and member states are trying their best to finalize before the end of this year. But as you remember, when they decided last May, they said if possible within this year, if not until May 2025. And they're doing their best to finalize this time, and we'll see how far they can go. And if not this year, then they may continue the negotiation next year. But we'll see. From my side, I think most of the things are addressed, and there is already a middle ground for many of the difficult issues. And if there is a will, there is a way. So it could be it's possible to finalize this year. And look forward to the meeting next week. Of course, they're giving it their best, and we'll see what the outcome of next week's engagement will bring. But whether, as Derek said, whether we'll have a special session or not, we will know during the 2 weeks of negotiation. But of course, there is good progress, and we have to also recognize that. International agreements like this take many years, as you know. It's only because our member states have really worked very hard that they have almost reaching to a deal, close to a deal, in not more than 3 years, I think. So that's actually going to be one of the shortest. But as you know, global agreements, international agreements actually take a lot of time, a decade, even more sometimes. So they're doing well, and we have to recognize that. I think we have to recognize that member states are doing their best. And this agreement, it's being negotiated by them, for the member states. and it will be implemented based on their national laws. I'm saying this because there are still some allegations flying around, especially in the social media, about WHO ceding sovereignty, but that's not right. And it's probably, I would use a strong word, it's a lie. It's an outright lie. This pandemic agreement is a negotiation by member states between member states for member states, and it will be implemented based on their national laws, meaning respects their sovereignty. So that's what we know, and what's flying around about ceding sovereignty is an outright lie. I repeat, it's a lie. So thank you so much. I think we're getting into a close, but I think Fadila, back to you.
If you allow me, DG, we have Helen Branswell patiently waiting to ask her question. So let's take Helen, last question. Helen, you have the floor.
Thanks very much, Fadela. It's a follow-up on the situation in Rwanda with the Marburg outbreak, please. Does WHO have any concern that Rwanda is missing cases in the community? A couple of the recent cases that were identified were not hospital cases. They were cases that had some contact apparently with the index case or from that chain of transmission. I was trying to get some further clarity about that yesterday in a briefing Africa CDC and Rwanda had. And the Minister of State mentioned that they think that some of their cases have had longer incubation periods than are, standardly thought to be the case, like longer than 21 days. I'm sure that's possible, but I think if I saw a case that was longer than 21 days, I might think I had missed some cases, and I'm wondering if WHO has any concerns about that. Thank you.
Thank you, Helen. I would like to ask Dr. Rob Holden to take this question. Rob, he's incident manager for Marburg. Thank you.
Yeah, good afternoon, Fadela, and hi, Helen. Thanks for your question. Fadela, can you just confirm that you can hear me? I've had a few challenges with IT this afternoon.
Perfect. We can hear you perfectly.
Helen, thanks. I think with any outbreak, and particularly with any VHF outbreak, we are concerned. We need to keep a high level of diligence with the ministry, with our partners. I think, there's no room for complacency. We're not complacent. I think, as you mentioned, the last couple of cases, were quite complex, and the follow-up on those cases has been quite challenging. I think we need to continue to increase on the surveillance side, particularly in those areas where we've got contacts, where we believe we had the cases, where we believe we had the index cases around the mines. So it's a question of ensuring that, as we go forward, as we support the ministry week from week, we fine-tune, we refine, reinforce all our surveillance systems, our contact follow-ups, our investigations, and we leave no stone unturned. Because I think if we let our guard down, then I think we'll end up with some nasty surprises and a very long tail on this outbreak. So yes, there is some concern. I think there is some optimism, but there's also an air of caution that we will continue to hunt every case. We'll continue to show great diligence with the ministry on every case follow-up, every contact follow-up, every alert follow-up, until we get to the end of this outbreak, whenever that might be. So I think, yes, concern, but that concern should be there regardless of whether the outbreak is in Rwanda or anywhere else. Back to you, Fadela.
Thank you so much. Now we have come to the end of our press conference. Thank you for your participation. We will be sending you the audio file of this press conference and Dr. Tedros' opening remarks. If you have any follow-up question, please don't hesitate to reach out to the WHO media team. With this, over to you, Dr. Tedros, for your closing remarks.
Thank you. So before I close, I would like to add to what Rob Holden had said on Marburg. I was in Kigali a week ago. I met the president and I met the minister and other officials as well. And the leadership by the president himself is really very, very encouraging, actually. He was on top of what's going on. And that kind of strong leadership is very, very helpful. And we have seen it in expediting some of the activities. For instance, as you know, they have started the vaccination trial and they did the approval quickly, and they have already, since the announcement of the outbreak in just a week, they had already started the vaccination. And therapeutics, again, trial ones started within days. And everything I have witnessed was really expedited. Not only that, as you know, they have done sequencing, they have tried to trace and see how it started, and looking into the index case, which they traced back actually even to an earlier days in August, although initially the index case was September, and that shows transparency as well. And not only that, in terms of clinical services, I think this is first time with Marburg. While we were there, they intubated and extubated 2 patients who could have died actually, and that's why the survival rate is high. So they're doing their best. But within that, our advice was for them to be vigilant, because as Rob said, there could be some surprises. But with a strong leadership, I think, and stronger surveillance, they can detect early and manage it. And that's what we expect. But there could be surprises like we had, if you remember, in Ebola, DRC, after we started counting down, and in Beni, then there were cases in Katwa, and then started counting down in Katwa, then Butembo reported. So they know, and we have discussed about this openly and honestly, and there could be some surprises, and that they have to be very, very vigilant. But I'm really encouraged by what I have seen during my visit. And then to the closing, today I'm proud to be wearing this white puppy for peace. The white puppy stands for remembrance of all victims of war, challenging militarism, and a commitment to peace. We need peace for health now more than ever. The best medicine is peace. And thank you, and to the members of the press, thank you so much for joining us today, and see you next time.